All of the following are clinical signs of bruxism, except one. Which one is the exception? Temporomandibular junction symptoms? Yes, that is a clinical sign of bruxism. Muscle soreness? Yes, that's also a clinical sign of bruxism. Periodontal pocket formation? No, that is not. Periodontal pocket formation is not a clinical sign of bruxism. Cracked teeth or fillings? Yes, that's also a periodontal sign. A clinical sign of bruxism. Wear faucets on teeth? Yeah, that is a clinical sign of bruxism. And widen periodontal spaces on radiographs? That is also a clinical sign of bruxism. So the only one that is not a clinical sign of bruxism is periodontal pocket formation. Periodontal pockets are inflammatory lesions that are not caused by occlusal trauma or bruxism. Bruxism is defined as biurnal or nocturnal parafunctional activity that includes clenching, bracing, gnashing, and grinding of the teeth. Although no causative association exists between bruxism and gingival inflammation or periodontitis, bruxism can cause tooth mobility, tooth wear and fracture, and periodontal and muscle pain, and it may contribute to masticatory system disorders. A maxillary or mandibular interocclusal appliance, like an occlusal splint or a night guard, is generally considered the most effective means of managing bruxism. They are used to retribute occlusal forces and to minimize excessive force on individual teeth, to stabilize the dentition, to modify the nature of the habit, to act as a splint after periodontal surgery, to assist in controlling recurrence of drug-induced gingival enlargement. Note: night guards are usually worn at night, but they may also be worn during the day. The primary purpose of a night guard in periodontal trauma is to modify and control bruxism or to redirect forces into a non-traumatic pattern. Night guards usually have the following characteristics. 1. They should be made of hard acrylic. 2. They should be no sharp edges. Needs to be comfortable. 3. They should fit well and cover the occlusal surface of the maxillary teeth. Should not cover the palate. And 4. They should occlude evenly with mandibular teeth and permit the patient to move the mandible freely in all excursions. Microorganisms that colonize the periodontal abscess have been reported to be primarily, microorganisms that colonize the periodontal abscess have been reported to be primarily 1. Gram-positive aerobic cocci. 2. Gram-negative anaerobic rods. 3. Gram-negative aerobic rods. And 4. Gram-positive anaerobic cocci. There will be anaerobic, so we have the two options: gram-negative anaerobic rods or gram-positive anaerobic cocci. I think gram-positive anaerobic cocci, maybe. No, I was wrong. The right answer is gram-negative anaerobic rods. So, microorganisms that colonize the periodontal abscess have been reported to be primarily gram-negative anaerobic rods. Principal differences between the periodontal abscess and the gingival abscess are the location and history. Abscesses confined to the marginal gingiva caused by injury, like forcing of foreign material to the outer space, Again, abscesses confined to the marginal gingiva caused by injury, forcing of material to the outer surface, of the gingiva and not involving the supporting structures are called gingival abscesses. A periodontal abscess is an infection located continuous to the periodontal pocket and may result in the destruction of the periodontal ligament and alveolar bone. The pericoronal abscess is associated with the crown of a partially erupted tooth. Periodontal abscesses can be classified as acute and chronic. In an acute periodontal abscess, the most prevalent symptom that the patient will report with an acute periodontal abscess is one of acute pain. The nature of the pain is constant, severe, dull throbbing. Thermal changes do not seem to elicit or modify the discomfort. The onset of this discomfort is rapid and becomes progressively more intense. Exudate may be expressed with gentle pressure. The patient may also notice an increase in mobility in the individual tooth. The patient probably will say that it is difficult to close his or her teeth together without striking the involved tooth first, because it feels elevated in the socket, causing increased pain. There may be systemic involvement characterized by an elevated temperature and lymphadenopathy. And a chronic periodontal abscess is usually characterized by no or a dull pain. So, a chronic is characterized by no pain or a dull pain, slight tooth elevation, intermittent exudation, fistulous tract often associated with deep pocket, and without systemic involvement. Treatment of an acute periodontal abscess is determined initially by whether there is localization of the abscess. If there is, then the treatment is to provide drainage, either through a periodontal pocket or through external incision. Instruct the patient to rinse with warm salt water and place chlorhexidine gluconate on the affected area with a cotton-tipped applicator. If there is systemic involvement, the patient should be prescribed antibiotics, either amoxicillin or, if allergic, then clindamycin or azithromycin. If there is severe swelling and inflammation, not localized, the patient should be put on antibiotics and seen once the infection has localized. Bacteria associated with abscesses of the periodontum. Bacteria associated with abscesses of the periodontum include Fusobacterium nucleatum, Porphyromona intermedia, Porphyromona gingivalis, Porphyromona micros, and Tenorella forsythia. As with the periodontal pocket, the chronic abscess is usually treated with scaling and root planing or surgical planing. The radiographic findings associated with these abscesses are not specific. There may be no change radiographically in early acute lesion. However, often in a chronic abscess, there will be a localized discrete radiolucency lateral to the root or in a furcation. Note, it can cause rapid alveolar bone destruction. In another note, microscopically, an abscess is a localized accumulation of polymorphonuclears within the periodontal pocket wall. The polymorphonuclears liberate enzymes that digest the cells and other tissue structures, forming the liquid product known as pus.